Hello and welcome to the Introduction to Ultrasound video series. In this first lecture we'll cover the fundamentals of bedside ultrasound. We'll briefly cover the physics of ultrasound, then go over the images produced and image terminology, and finish with a brief introduction to the probes and how to use them. Starting with ultrasound physics, we'll focus on two areas, the piezoelectric effect and some basic definitions to help understand how images are created. The foundation of medical ultrasound is the piezoelectric effect, which is a relationship between electric and mechanical forces observed in certain substances, including ultrasound crystals. When electricity is applied to a piezoelectric substance, mechanical change is observed. The reverse is also true. Mechanical distortion of a piezoelectric substance causes electrical charge in that substance. This reversible exchange is how the ultrasound machine interacts with tissue to provide images. Each ultrasound probe contains piezoelectric crystals, which have the properties just described. When electrical pulses are applied to the crystals, they rapidly vibrate and produce ultrasound waves. This process exemplifies the forward direction of the association just described in that electricity is used to create mechanical ultrasound waves. These waves then travel into the tissue where they are reflected back at variable times and intensities. Returning ultrasound waves hit the crystals causing mechanical distortion which, due to the piezoelectric effect, creates electrical current that the machine captures and processes to produce the image on the screen. This process exemplifies the reverse direction of the association as seen on the earlier slide, whereby mechanical distortion of a piezoelectric substance causes an electrical current. Next, there are a few basic definitions that will help explain how the ultrasound machine creates images. These are velocity, frequency, and amplitude. Velocity is the speed of the ultrasound wave, and it is constant in a given medium. Assuming that the velocity of waves is constant, signals that take incrementally longer to return to the probe can be assumed to be incrementally farther away. This is how the ultrasound machine interprets depth of tissues. For example, let's say we're going to ultrasound this kidney. This is what our screen might look like before any waves hit the tissue. To help orientation with the image on screen, you can imagine the probe sitting on top of the screen pointing downward into the tissues, as this is how they will be relayed. The first waves to return to the probe will be those reflected off the top of the kidney, as they have the shortest distance to travel and we assume all waves have the same speed. The faster the waves return, the closer the ultrasound machine interprets the reflecting tissues to be. The machine will plot these fast returning waves at the top of the screen, representing tissues relatively close to the probe. Waves reflecting off deeper tissues will take longer to return to the probe because they are traveling a greater distance, and we assume that all waves have the same speed. These slower to return waves are interpreted as farther away and therefore are plotted at the bottom of the screen, representing tissue that is relatively far from the probe. The assumption of constant wave velocity is the basis for how the ultrasound machine interprets depth. Frequency is the number of wave oscillations in a given period. For example, this yellow wave represents a relatively low frequency as compared to the purple wave, which has more oscillations in the same period and therefore a higher frequency. Lower frequency waves are better at maintaining energy over distances and therefore achieve better images of deeper structures. This ability to relay deep information is also known as penetration. Higher frequency waves are better at relaying detailed echoes over shorter distances and are therefore preferable when penetration is not a priority, but detail, also known as resolution, is. An example that may help understand this concept is that of audible sound. Imagining a neighbor playing music, it's mostly the low frequency bass notes that penetrate the walls and travel distances well enough for you to hear. The high-frequency notes have lost their energy before they got to you, and while the bass notes are audible, the level of detail they contain is minimal. Now imagine sitting right in front of your speakers or wearing headphones. The level of detail is greatly increased by the high-frequency sounds which now have no trouble reaching you over the shorter distance. The frequency of waves created for medical ultrasound purposes depends on the probe and settings used, both of which will be discussed later. Amplitude is defined as the peak deviation of oscillations from the baseline and for ultrasound is measured in terms of pressure. Think of amplitude as the loudness or intensity of an ultrasound wave. If you superimpose the waveforms from the previous page, you can see that, while the frequencies are quite different, the amplitude of each wave is the same. As a comparison, the purple wave with increased amplitude would look like this. You can see that amplitude is independent of frequency as this wave has the same number of oscillations, it's just that the deviation of each oscillation is greater. Similar to how the timing of returning waves is used to plot depth on the screen, the amplitude of returning waves determines how bright these points will be. Areas of strong or high amplitude reflected waves are plotted as brighter points on the screen. Areas of weak or low amplitude waves will be visible as darker points on the screen. This leads us nicely into our discussion of image interpretation, beginning with echogenicity, which is another term for brightness of reflected waves, as we just discussed. As a default, ultrasound images are displayed in grayscale, and relative brightness of an area is described in terms of echogenicity. Hyperechoic areas are brighter than the surrounding tissue and represent reflected waves of high amplitude. Hypoechoic areas are darker than the surrounding tissue and represent reflected waves of relatively lower amplitude. Anechoic areas do not reflect waves and are displayed as black. Attenuation describes a decrease in amplitude that ultrasound waves experience in transit. Technically, attenuation is the loss of amplitude for any cause, but for our purposes there are two main factors that contribute to the degree of attenuation. These factors are absorption and reflection. Absorption is the primary form of attenuation in soft tissues and reflects the energy lost as heat during propagation of the wave. Think of absorption as the tax on an amplitude for moving through a particular substance. This image shows decreasing intensity of returning waves as they are reflected back from deeper in the tissue. The liver tissue at the bottom of the screen is not any less echogenic, but it appears darker because the waves have lost amplitude propagating through all of the above liver tissue. The amount of absorption is variable and is influenced by the type of tissue encountered and the frequency of the wave. As mentioned before, lower frequencies have better penetration into tissues. One of the reasons for this is that they suffer less absorption when propagating through tissues and therefore are able to return brighter images from deeper structures. This is the scan from earlier on the left, now compared with the same scan using a lower frequency probe on the right. You can see the lower frequency probe achieves better penetration, having suffered less absorption, and is capable of relaying a more balanced image of the full liver parenchyma. Reflection is the amount of the wave bounced back at the source, just like it sounds. We rely on small amounts of reflection to create all of the images we see using ultrasound. Certain substances, however, such as bone, reflect waves so strongly that we are unable to visualize structures beyond their border. This is also referred to as acoustic shadowing, and is seen in this lung ultrasound here, behind the two ribs labeled with Rs. The official cause of reflection is differential impedance between adjacent tissues. Impedance is influenced by tissue density, and strong reflectors, such as bone and air, often lie at the extremes of the density spectrum. Lastly, the sum of all attenuating factors is numerically represented as the attenuation coefficient for a given tissue. Tissues with high attenuation coefficients, such as gas or bone, will greatly reduce the amplitude of propagating waves. Tissues with low attenuation coefficients, such as fluid, will allow wave propagation with minimal effect on amplitude. Resolution is the ability to see two different structures as distinct. In a high-resolution image, even if small objects are very close together, they can still be visually differentiated from one another. In a low-resolution image, these objects will appear blurry and indistinct. Resolution can be further broken down into lateral and axial resolution. We'll start with an image that has both high axial and high lateral resolution, like the one in the last slide. If we take away some of the lateral resolution, which is the ability to differentiate objects side by side, we get an image like this. If we give back some of the lateral resolution and now take away axial resolution, which is the ability to differentiate objects above and below each other, we get an image like this. Different factors affect axial and lateral resolution, but it is mostly important to remember that high-frequency waves achieve better resolution in both axes when compared with low-frequency waves. Now, onto the probes. There are typically three types of probes kept with each machine: a high-frequency linear probe, a phased array probe, and a low-frequency curvilinear probe. Each probe has an indicator on one side to ensure proper orientation. This indicator corresponds to the indicator on the screen such that tissues scanned under the indicator side of the probe will be displayed on the indicator side of the screen. Remember also the earlier orientation tool of imagining the probe sitting on top of the screen, making sure that the indicator sides line up. Thinking of the image on screen as what the probe sees when looking down into the tissue may help with orientation. The default location of the indicator for most settings will be on the left side of the screen. For certain exams, including the cardiac exam, however, the screen indicator may be switched to the right side of the screen. Be sure to double-check the location of the screen and probe indicators if you ever feel like the image orientation isn't making sense. This is the high-frequency linear probe. You may hear this probe referred to as the vascular probe. The name comes from the frequency of waves it is engineered to emit, in this case high frequency, and the footprint of the probe, which in this case is flat, or linear. Images produced by the linear probe will be rectangular since the ultrasound waves are sent and received directly along the vertical axis. As we discussed earlier, high-frequency probes sacrifice depth of penetration for better resolution, which is why this probe is good for things like vascular access and ocular ultrasound, where target tissues are relatively superficial. This is also the probe used in lung ultrasound. Next is the phased array probe, also called the cardiac probe, though it has other uses. This probe also has a relatively linear footprint, but the term phased array means that this probe emits waves from a focal source in an arc that will produce a wedge-shaped image. This is the wedge-shaped image produced by the phased array probe. The small footprint of the phased array probe makes it good at sneaking views in between rib spaces, which is helpful when performing echocardiography and as an alternative to the curvilinear probe for the FAST exam. Last, we have the low-frequency curvilinear probe, which you may also hear referred to as the abdominal probe. Compared to the phased array probe, this probe trades the downside of the larger footprint for the upside of not needing to electronically steer its beams from a focal source. This probe also creates a wedge-shaped image, and since this probe has a low frequency and a wide field of view, it is useful for visualizing deep structures like those in the abdomen. There are three planes in which most ultrasound scans will be conducted. These are the transverse or axial plane, longitudinal or sagittal plane, and the coronal plane. Scans in the transverse axis will have the probe on the patient's front or back side and take horizontal or left to right cuts of tissue. The convention for scans in this axis is to have the probe indicator pointed toward the patient's right side. Scans in the longitudinal axis will also have the probe in the patient's front or back side, but will take vertical or top-to-bottom cuts of tissue. The convention for scans in this axis is to have the probe indicator pointed toward the patient's head. Lastly, scans in the coronal axis will have the probe on the patient's side and take vertical or top-to-bottom cuts of tissue. The convention for scans in this axis is also to have the probe indicator pointed toward the patient's head. Now for a quick review. The ultrasound machine uses piezoelectric crystals to turn electricity into mechanical ultrasound waves, bounces them off of tissue, and then interprets the time and intensity of returning waves to create an image on screen. Velocity of ultrasound waves is assumed to be constant. We can therefore use the time it takes for a reflected wave to return to the probe as a proxy for distance of tissue from the probe. Low-frequency waves maintain energy over distances and are better for tissue penetration. High-frequency waves lose energy quickly over distances but offer superior spatial resolution. Amplitude is the loudness or intensity of the ultrasound wave. Areas of stronger or higher amplitude reflected waves are plotted as brighter points on the screen. Areas of weaker or low amplitude waves are darker. Attenuation is the loss of wave amplitude in transit for any reason, but is primarily caused by absorption, which is the cost of propagating through tissue and depends on frequency and tissue type, and reflection, which is caused by interfaces with strong differences in impedance, which is related to tissue density. All factors combine to form an attenuation coefficient for each tissue, where a higher number correlates with a greater loss of amplitude in that tissue. Resolution is the ability to differentiate between distinct objects. It can be further broken down into axial and lateral resolution. High-frequency waves achieve better resolution than low-frequency waves. The high-frequency linear probe has good resolution and poor penetration. Common uses include vascular access and lung ultrasound. The phased array probe has a small footprint that is helpful for viewing structures in between ribs. Common uses include echocardiography and the FAST exam. The low-frequency curvilinear probe has good penetration and a large field of view, making it the probe of choice for abdominal exams. The good penetration of low-frequency probes comes at the expense of resolution. The transverse axis takes horizontal or left-to-right cuts of tissue. The probe indicator should point to the patient's right side. The longitudinal axis takes vertical or top-to-bottom cuts of tissue. The probe indicator should point to the patient's head. The coronal axis will take vertical or top-to-bottom cuts of tissue through the patient's side. The probe indicator should point to the patient's head. That's it. Thanks for watching, and look for more videos to come.